Hello, this is Michael Rojas. I'm doing my quality presentation for A.T. Still University, Arizona School of Health Sciences for the Doctor of Medical Science program, Dr. Sandra De Palma. My presentation is titled Capturing At-Risk Patients with Osteoporosis. The agenda is the following for my presentation: background on osteoporosis, incidence, risk factors, and potential complications. The type of practice I plan to do this quality improvement, as well as key factors related to quality improvement, describe important processes, management skills used, as well as the implementation of the process, which steps I took, and ultimately the conclusion. Osteoporosis is a public health crisis due to the large amount of population being affected. 44 million people have osteoporosis in the U.S., with a 1.5 million fragility fractures each year. Economically, it accounts for $17.9 billion annually in costs. 1 out of 2 women and 1 out of 5 men over 50 years old develop osteoporosis in their lifetime with related fragility fractures. Medical professionals found that we ineffectively identify at-risk patients and initially treating these patients in the U.S. Risk factors. Approximately 50% of hip fractures never fully recover with mobility and independence. An additional 25% require a long-term nursing facility or home care, and the mortality rate is 6 months after a hip fracture, 12 to 35%. The image is of a compression fracture with a identified normal vertebra versus the compression fracture, which is very common for elderly to have. Introducing the QI project. Currently, my department of orthopedics, they have a program trying to identify older women with osteoporosis who present with fragility fractures. We are trying to address the condition previously noted, where medical society in the U.S. Has been having a difficulty time identifying and treating osteoporosis. The denominator used in my facility department is female patients between the ages of 67 and 85 at the time of their fracture presentation. The purpose at this time is to determine the percentage of fractures captured with these females in particular, and if we have addressed the initial management for osteoporosis. Currently, osteoporosis management involves, once a person is identified per the denominator, bone scan should be evaluated if done within the last 180 days. If not, it should be ordered. Osteoporosis therapy should be started or have a history of being taken since the last 180 days. If not, initial therapy should be started. Third, a referral should be done for endocrinology, primary care provider, or rehab specialist within orthopedic department who does the initial workups if it has not been done in the last 180 days. The findings currently in our department for capturing these individuals has been roughly 75 to 90% capture rate every 2 months has been evaluated. The goal for management is 100% capture. The following is the problem statement that I have identified. Inadequate identifying and treating osteoporosis. Studies demonstrate many patients with fragility fractures were found not to have had a workup or treatment to reduce the risk of future fractures. Key factors and objective for my QI. Initially, the key factors are that our orthopedic department management is aiming at 100% capture rate of osteoporosis patients with fragility fractures, which, as noted earlier, has not been reached. The second, a successful percentage rate has been linked to the annual compensation packages for the surgeons. This was an attempt by management for an incentive. The goal of my QI is twofold. First is to evaluate the process of the current osteoporosis process and see if any changes can be made, identify weaknesses, and make changes as needed to capture the 100 rate of osteoporosis patients. Second is simply to identify at-risk patients, to initiate vital workup and start therapy and management. Management skills used and tools used are the following. Initially, a group was formed involving people who were invested in the program, such as the doctors, surgeons, APPs, nurses, and MAs. Specific activities which were done were fishbone cause and effect diagrams. Process flow charts was also used, and also the aim statement using SMART criteria was used so to keep everything focused and clear for our goals. Participation was used quite heavily in these meetings, with everyone investing some time and effort. Everyone was heard. The information which came from these meetings were also disseminated to every department, so everyone would be aware of where we were at, what were the goals, so there was transparency in the process. To keep the group in focused, or the aim, we used the SMART tool. Our aim was to improve percentage of capturing at-risk patients with fragility fractures / osteoporosis to 100% as management requesting. Second was how to measure this improvement, which we found to be best done with a weekly report that identifies all individuals with the common denominator previously noted and which ones we had addressed, showing how many we had captured. The third question was, what can we make that will result in improvement? This was difficult initially due to, first we needed to assess the current process and look for weaknesses. Then we could answer this question much better. After 2 or 3 meetings with these specialized groups from different areas of our department, we were able to find gaps and weaknesses in the process and found recommendations for / changes for these weaknesses. Number 1, we found that providers were at times not evaluating for osteoporosis when they should have. The recommendation was for nursing to initially highlight charts for providers who fell within the denominator. So this would cue the doctors or the APPs to start the workup or further evaluate. Second, patients were at risk for falling through the cracks for different reasons. So to counteract this, we recommended to have printouts weekly through management of all the identified individuals for the denominator, so to make sure we would not have anyone fall through the cracks. And third, due to these patients that did fall through the cracks or lacked a complete workup, APPs volunteered to, on a weekly basis, to review all identified individuals and make sure they were worked up or referred. Steps used for managing of changes were done as the following. As the diagram on the right indicates, the first step was to define the changes. Using the SMART tool, we were able to focus on the aim, keep everyone focused, and we identified the need to identify a high-risk group of individuals for osteoporosis. We defined it and made sure to have a definitive goal. Second, prepare for change. This is by identifying the impact, communicate the change, and we did this by showing or telling everyone with emails disseminating information regarding the cost of healthcare, of this condition and the complications for not treating osteoporosis. This is to make a sense of urgency as recommended to get people motivated. The third implementation of change, which was done by a projected timeline, which will be presented in the next few slides, where everyone was together at putting these dates together and projecting, and also was disseminated so everyone would know what the process was going to be. And the last, fourth, support the changes. This was done by keeping everything in transparency throughout the whole process, sending out emails, having everyone report back to their departments where we were at, and any complications or problems or new information was brought back to the meetings and were addressed as needed. The following is the timetable we had planned. Unfortunately, due to the pandemic, COVID-19, there were some slight changes from the initial timetable. Due to we weren't able to have meetings together with a large group, we had to make multiple meetings, which not everyone could attend, but we would disseminate the information with emails, and everyone who attended the meetings made an effort to present the information to their department areas. Also, the onset of the changes, rather than initially on 4/27, were done on 5/4/20 due to the COVID. But we have learned to be flexible and make changes as needed. As previously noted, the interventions were not initiated until 5/4/20. We held for 2 weeks, then checked the evaluations or the progress. On 5/11/20, reports indicated we had captured 95% of the high-risk patients. We believe we were not at 100 due to the process was new, providers were unsure. We looped back with this information, reinforcing information to the providers, encourage them, reminding them of the association with their end of the year reimbursement, and we had also the staff, the administration staff also help. On 5/18/20, another report came out. Surprisingly, it came out with 70% of capture rate. We were not aware that administration had added other outside clinics, orthopedic surgeons from our area onto our program, which dropped our percentage rate. But looking specifically at Round Rock, as well as one provider in Pflugerville and another one in Lakeway, who were with our department initially and knew of the program, we were all at 100% capture rate. The following is the same information I spoke of earlier, but is in a diagram for people who are visual like myself to review. The following is what I describe as outliers, which really were unforeseen complications, or the added of the new surgeons from our region area, which did drop our percentage rate. These outside regions, which we were not aware of, were literally 0% capture rate. What we plan to do for them, or the intervention, is after our orthopedic director, Dr. volunteered, he plans to meet with all of these providers outside of our immediate area of our hospital in Round Rock, Texas, and advise them of this process. We were also sending a email with instructions on how to move forward with this process, and as well as the reasons for importance, not only for the patient, but for their yearly reimbursement incentive. This should help them, kind of encourage them to do or participate in this program. Also, we will see in the future if these interventions make any difference in our future reevaluation. Using the data we get weekly from management on captured rates. These are my references. I apologize for running later than was required. I just had a hard time condensing all the information. I hope everyone has a good summer. Thank you.